said, my name is Sarah Riley. I am the medical director of the STEP Clinic, and today I'm going to talk about catatonia. I put this presentation together after we received several referrals from the hospital of patients who were treated for first episodes of psychosis with prominent catatonia. And each of these patients were discharged on relatively high doses of benzodiazepines. And so I found myself looking to the literature to make sure that I was giving them the best care possible. And what I found was that there were no studies on how or when to discontinue benzodiazepines in these patients. And the more I read, the more I realized that catatonia is quite poorly recognized even by medical providers. And so it became clear to me that more education was needed in this area. And so I thought it would be a helpful topic to cover. So we will discuss an overview of catatonia, its clinical features, and its management. So let's start with the basics. What is catatonia? Catatonia is a distinct neuropsychiatric syndrome made up of motor and behavioral abnormalities. It used to be considered a subtype of schizophrenia, but it is now considered to be one of three different categories. So it can be categorized as either catatonia associated with a mental disorder, catatonia due to another medical condition, as well as unspecified catatonia. Now, the psychiatric conditions that can cause catatonia are varied, but they include psychotic illnesses, mood disorders, and neurodevelopmental disorders. Now, currently as an outpatient provider myself, I want to acknowledge that most of us on this call are likely outpatient providers, clinicians. And so I want to be very clear that if a patient is newly presenting with symptoms of catatonia, that they should go to the hospital. Catatonia can become dangerous quite quickly, and it can lead to significant complications if it's not treated early. That said, we as outpatient clinicians and providers do need to know how to recognize catatonia because we can only direct people to the appropriate level of care if we know the signs to look for. Like I said at the beginning, we might also be taking care of patients who are sent to us after recovering from an episode of catatonia. And in those cases, we need to keep a close eye out for signs of recurrent catatonia symptoms. So speaking of recognizing catatonia, what does it look like? It can present differently from one patient to another, depending on which specific symptoms, of which there are many, are most prominent. So most often it presents as a decrease in speech and movement, but we can also see unusual interactions with the environment and the examiner, and in other cases, the presentation is more hyperactive. This variability in presentation is part of why prevalence estimates of catatonia are quite imprecise. So there was a New England Journal review of catatonia done in 2023, which estimated the prevalence to be between 9 and 20% on inpatient psychiatric units and less than 10% on medical units. So I mentioned that I learned how under-recognized it is, and this is a study published in 2021 that really nailed that home for me and showed just how much room for improvement there is in the recognition of catatonia. So these researchers did a study and they included 482 participants. The participants were either medical students or psychiatry residents or attendings. And they gave each participant a 50-item multiple choice test about catatonia. And they also showed them each a video exam of a standardized patient and asked them to identify signs of catatonia. Well, the results showed that overall, across all participants, the average score was 55% on the multiple choice test, and 69% of items identified correctly on the video exam. And so obviously that's not great, right? And what was interesting was that the training level only impacted the results slightly. So attendings on average did about 6.8 points better on the multiple choice and identified 2 more items correctly on the video than trainees. My takeaway from this was that we all need to get better at recognizing catatonia. So now we'll go through the specific signs of catatonia. And the next 3 slides are taken from that New England Journal review in 2023 that I mentioned. And it includes a table. I split it across 3 slides and outlined 16 different signs of catatonia, ranked and grouped by how commonly they occur in clinical settings. So they're characterized as either high frequency, moderate frequency, or low frequency. And these 4 signs on the first slide are the high frequency signs seen in catatonia. So these are what we'll see most commonly in a patient presenting with catatonia. And they are, first, staring. Now that one is relatively self-explanatory, but refers to a fixed gaze with minimal visual scanning of the environment and maybe decreased blinking. Stupor describes extreme immobility or hypoactivity with minimal to no reactivity to external stimuli, even painful ones. So patients will appear very withdrawn and even can look unresponsive. Mutism refers to severely limited verbal output. So it can range from no speech at all to an incomprehensible whisper. And posturing involves the spontaneous maintenance of a posture. It can be either bizarre or mundane, and that they can maintain that posture for minutes to even hours. And when I say mundane posture, I'm referring to either sitting or standing and not shifting at all. So the actual, it doesn't look like they're doing something bizarre. It's more mundane, but the abnormality is in how long it's held and how still they are. Now, these 4 signs are all signs that obviously you can observe very quickly when you see someone, and you don't need to do anything special to try to elicit them. Now, these 7 signs are the moderate frequency signs in catatonia. So the first here is ambutendency. And ambutendency refers to hesitant or incomplete movements where someone will appear sort of stuck or interrupted. And the classic way to assess for this is to extend your hand to shake the patient's hand. And in cases of ambutendency, the patient will start to reach and then they'll stop. They'll sort of freeze mid-motion. And another way to, another time you might see this is if they're reaching for, the phone or a cup, and again, kind of stop halfway through. So look stuck. Negativism is defined as motiveless resistance or contrary behavior. And that's when a patient resists instructions during your exam for no clear reason. So this might include doing the exact opposite of what you ask them to do, might refuse to shake your hand. In a patient who's immobile, you can test for this by trying to open their eyes. And if they resist passive eye opening or really clench their eyes shut on your attempt, that would be an example of negativism. And I just want to say here with negativism that you don't score someone for negativism if they simply fail to stop another catatonic behavior when you ask them to. So if they're stuck in a posture and you ask them to shake your hand and they don't, that's not them being kind of contrary. It's just the nature of catatonia and them being stuck in another symptom. Stereotypy refers to repetitive, non-goal-directed movements like rocking, repeatedly patting oneself, playing with one's fingers. And what's abnormal here is not the movement itself, but the repetition of that movement. And this is in contrast to mannerism, which I'll talk about at the end of this slide. Next up is rigidity, fairly self-explanatory, refers to increased muscle tone. And then agitation refers to excessive emotional excitability or hyperactivity, excessive motor activity. Grimacing refers to the maintenance of odd facial expressions. And mannerisms are exaggerated movements that appear purposeful but are odd or out of context. And so an example of this might be walking on one's tiptoes or making an exaggerated driving motion with an invisible steering wheel. So the patient might be, doing something like this. That would be a mannerism. These next signs are the low frequency signs. So they're seen least commonly in patients with catatonia, but they're still very important for us to recognize. So these include echolalia. This is repetition or imitation of the examiner's speech. Echopraxia involves mimicking of the examiner's movements, and this is one that you can proactively test for by making a deliberate gesture, say touching your ear or scratching your forehead and watching them to see if they do the same thing. Verbigeration refers to the senseless repetition of words or phrases. So patient might say, go home, go home, go home, over and over and over again. And this has been compared to sort of a broken record. So sounding like a broken record, just repeating the same thing again and again. Next is waxy flexibility. Waxy flexibility is a bit of a confusing one because it is defined differently in different sources. So the definition included here is slight and even resistance to positioning by examiner. That is the DSM definition of waxy flexibility. That's not actually the best definition or the definition that most psychiatrists would call to mind when thinking about what waxy flexibility actually looks like. The Bush-Francis Catatonia rating scale, which I'll discuss further, defines it in sort of a more clinically accepted way, which is similar to if you can think about bending a candle. It is when a patient has an initial resistance to repositioning of, say, their limb. They initially are quite stiff. It's hard to move that limb. Then they allow the limb to be repositioned and moved, and then they hold that posture once you're done moving them. And so you can test for this when you're testing for muscle tone in the arm often. It's similar in a way to catalepsy, and I'll give examples to kind of help clarify the differences between these two. But catalepsy is when a posture is passively induced by the examiner and then maintained by the patient. So it's similar to waxy flexibility, but it doesn't specify that initial rigidity when you first try to move them. And so catalepsy is also very similar to posturing. Posturing, though, is when the position is spontaneously assumed by the patient, and catalepsy is when the examiner moves the patient and puts them in a position. And again, you can check for this when you're assessing for tone. So now, in order to sort of consolidate, that was a lot of information. In order to kind of consolidate it, I have some examples, and I'd like you to just kind of try to think about, as I describe the sign, what I'm referring to. And here we're going to focus on signs that are often confused for one another, even by trainees and professionals. So name that sign. You lift a patient's arm above their head and they keep it raised even after you let go. What would that be? Would that be posturing, waxy flexibility, catalepsy? Answer is catalepsy. And we'll draw a distinction here to the next one. You walk into the room to find your patient has their arm extended and held up against gravity. What am I referring to here? I'll give it a minute. That is posturing. And the key difference between these two is that it's specified that in the first, the examiner is lifting the patient's arm and imposing the position on the patient, whereas it's spontaneously assumed in the second. And now if I wanted to describe waxy flexibility here, how could we modify this and be consistent with the commonly accepted definition of waxy flexibility? Well, we could say We would have to, going with the first example, you lift a patient's arm above their head. You'd have to add in something on a vignette about that initial resistance, that initial tension and difficulty moving their muscle. Then they kind of go with the flow, let you reposition them and keep it raised. So that would be a description of waxy flexibility. And waxy flexibility is pretty rare, but it's almost pathognomonic for catatonia, meaning that there are very few other things that cause it. So if you see waxy flexibility, you should be thinking about catatonia. Name that sign. The patient bows to you multiple times during your interview. What would that be? Would it be stereotypy? Would it be mannerism? Something else? Correct answer is mannerism. So that gesture, bowing, has a cultural meaning. And that gesture in and of itself is being used out of context, sort of odd for someone to be bowing to you during an evaluation, right? So it just appears out of place. Oops, sorry, I gave the next one away here. Patient rocks back and forth in their chair. The distinction I wanted to draw here is that would be stereotypy. The abnormality here is in the repetition of the movement. The movement itself is not sort of odd or out of cultural context. And this is the last one. In response to you asking, "How are you doing today?" the patient repeats the phrase, "The dog ran away, the dog ran away, the dog ran away." What would that be? Would that be echolalia? Would that be verbigeration? Would it be something else? That is verbigeration. Remember that it sounds sort of like a broken record. Next, when asked, "How are you doing today?" the patient responds, "How are you doing today?" So they're imitating you, they're copying your words. What would that be? That would be echolalia. Okay, so hopefully that helped. These get confusing and require refreshing even amongst us as medical professionals if it's not something that we're seeing on a day-to-day basis. So now we're going to talk about how catatonia is defined in the DSM-5. The DSM-5 recognizes 12 signs of catatonia that are listed here. We've already reviewed all of them. And in order to diagnose catatonia, the patient needs to have 3 or more at the same time. And in contrast to the DSM, the ICD system lists 15 signs. And if you look closely at those 3 slides with the tables earlier in the presentation, listing all the signs, there are columns there you can refer back to that tell you which sign is included in the DSM, if it's included in the DSM, and then if it's included in the ICD. So the 3 signs that are included in the ICD, but not the DSM, are staring, verbigeration, and ambitendency. This isn't something that we usually have memorized or know offhand even. It's really just important to know kind of the spectrum of symptoms and that there are multiple tools out there and different definitions. One that gives us a little bit more of a granular approach and a more clinically useful approach is the Bush-Francis Catatonia rating scale, which I'll describe. And that one goes through 23 different symptoms. And again, so we do need to know how the DSM defines catatonia, but if we just use the catatonia, we might miss kind of the full spectrum of cases. About a month ago, a group of experts on catatonia came together and published a resource document through the APA, which is extremely helpful. I've linked it in this QR code here. It's also cited at the end of the presentation. And this table is taken from that document. I found it quite helpful because it lays out the full range of catatonia symptoms and highlights how each of our available tools captures slightly different aspects. It also clarifies on the left side whether a given symptom is something that we observe, something that we need to try to elicit. And we've already kind of talked through the symptoms that are included in the two rightmost columns, the ICD and the DSM. So I want to draw attention to the middle two columns, which cover the Bush-Francis Catatonia ranking scale. And there's sort of two different versions of it. The first, the leftmost, is the screening instrument version. And that one consists of 14 signs. As the name suggests, it's a screener. So it's your first step. If you suspect that someone has catatonia, you would do the screener. If they score 0 or 1, if they have 0 or 1 of the symptoms, you don't need to go on to the full screening instrument. They don't have catatonia. If they score 2 or more on that instrument, then you're going to want to do the full Bush-Francis Catatonia rating scale, which has 23 items. We'll talk more about the Bush-Francis as well. Like with most aspects of catatonia, the timing and course are variable. Onset can be rapid or it can be gradual. Some patients will improve immediately with a benzo and can then come off of it fairly quickly, whereas other patients have a more stubborn and more persistent course that persists for weeks or even months, and those patients might be harder to wean off of benzos. Some patients might experience intermittent symptoms, and some patients do end up experiencing recurrences of catatonia. And when a patient does experience recurrences, they're typically triggered by stressors or changes in medical status. So if you have a patient who's had recurrent catatonia in the past, it's something that you want to be mindful of during times of heightened stress in their life. If there are, certain stressors going on, if there are significant medical illnesses, those would be times that you'd want to be thinking about this and kind of monitoring closely. Malignant catatonia is a life-threatening form of catatonia, where you see the typical symptoms of catatonia, but you also have, in addition, you have unstable vital signs or autonomic instability. That's what that means. You have an altered level of arousal or wakefulness. So they might be really lethargic, falling asleep. And you also have prominent rigidity, which can lead to elevated levels of a serum marker, blood marker called creatinine phosphokinase. Malignant catatonia is similar to both neuroleptic malignant syndrome and serotonin syndrome, which are also psychiatric emergencies. And there's actually some thought that they are etiologically related. So these should be on your differential if you're seeing someone with malignant catatonia. And it's actually thought that both NMS and serotonin syndrome may be pharmacologically induced forms of malignant catatonia. So looking at someone's medication list is going to be crucial in these instances in determining which diagnosis they have. But regardless, malignant catatonia is a medical emergency. It requires early and aggressive treatment and close, intensive follow-up and care. There are a number of different complications that can result from catatonia, and the prolonged immobility, in particular in the more hypoactive forms of catatonia, can put someone at risk of a lot of different things: contractures, pressure ulcers, deconditioning, pulmonary embolus, aspiration pneumonia. You can also see nutritional deficiencies because a lot of times patients aren't eating or can't feed themselves. You can see dehydration, which can cause electrolyte abnormalities or kidney injury. And patients are also at risk of UTI and urinary retention. So there are a lot of potential sequelae, and that is why it's important to address early and aggressively. Now, the underlying neural mechanisms of catatonia are largely beyond the scope of this talk, but I wanted to emphasize that we do have some ideas about what causes catatonia, although it's extremely complex and we still have a lot to learn in the field in general. At the neurotransmitter level, there's probably most robust evidence to suggest a reduction in GABA A activity. And that is an inhibitory neurotransmitter. We know this because when we treat someone with a benzodiazepine, we see almost immediate improvement. And benzos work by enhancing GABA A's inhibitory activity, so it makes it work better. And so that really suggests that a reduction in GABA A is kind of one of the root causes. It's less clear with GABA B, but we think that levels are increased. And we also believe that there are alterations in both dopamine and glutamate underlying the motor and behavioral changes that we see in catatonia. There's also the level of neural circuitry, and there's several networks that are involved in behavior, motor system, affective system that could be affected in catatonia. And the specific sites where we see disruption really correlate with the specific symptoms seen and may be different from patient to patient. So what we see on neuroimaging is going to be more consistent between patients who have hypoactive catatonia, may be completely different from what we see in more hyperactive catatonia. Again, quite complex. Wanted to mention that there's a lot of ongoing research in this area. So we'll shift gears now and we'll discuss the clinical management of a patient presenting with catatonia. What should you be thinking about when you're evaluating someone? In terms of history, oftentimes you're not getting these details from the patient themselves, depending on sort of how they're looking. They may not be able to give you a reliable history, and in those cases, very helpful to use both medical record and also family, friends, collateral sources of information. I mentioned that it's important to get an accurate and up-to-date medication list, and this becomes especially important, like I mentioned, if there's rigidity on exam, because you're going to be specifically looking for serotonergic agents as well as dopamine antagonists, which could cause NMS. The use of substances is also very important to elicit because cannabis and cocaine could cause catatonia presentation, and withdrawal of other substances, withdrawal from, say, alcohol or benzodiazepines could also cause catatonia. You want to know what their underlying medical and psychiatric history is, because you want to also be thinking, not about just, treating the catatonia, but thinking about what it's stemming from, what underlying condition, whether medical or psychiatric, and so that you're treating that too, thinking about future risk. When looking at your physical exam, important to do a comprehensive physical. This is when they get into the hospital. And vital signs are incredibly important to monitor because they can be elevated. You could have an elevated temperature as an element of malignant catatonia. You could have alterations in blood pressure, heart rate, which would increase your level of concern for the acuity of their presentation. In particular, the neurologic exam is going to be important because of the cases of catatonia resulting from medical causes, 2/3 are neurologic in nature. And then in terms of early assessment, the Bush-Francis scale is important to do clinically because it's going to be something that, sorry, I don't know if you can hear the drilling above my office. I was hoping this wouldn't happen during this hour, but the Bush-Francis catatonia ranking scale is going to be something you're going to do initially. It's going to be something that can give you an assessment of the severity so you can monitor how they're responding to treatment. In terms of diagnostic tests, basic labs like CBC and CMP can be helpful to get initially, just to give you an overall picture of their health. And because sometimes you're concerned that there's a medical illness or maybe even a delirium going on, these can give you a sense of their hydration as well. And creatinine kinase, as I mentioned, in patients who are really rigid or not moving, creatinine kinase can be elevated, and monitoring that can help us watch out for the consequences of that, which could include rhabdomyolysis or kidney injury. Urine tox screen, because as I mentioned, the substance use could be playing into catatonia here. And then major caveat with the rest of the slide. So the majority of patients we're seeing, obviously in our clinic, have a primary psychotic illness. And if they have catatonia, it's pretty safe to assume that it's due to their psychotic illness. We are not getting an MRI, an EEG, a lumbar puncture on these patients. It's very, very few patients that we're actually going to do quite an extensive medical workup on. And those are going to be patients that we really have a high suspicion. Maybe something's off on their neurologic exam, or maybe there's something else about their presentation that makes us think that there's something neurologic going on. And if we suspect a neurologic cause, we're obviously going to consult with neurology and have them guide us in terms of what imaging, what tests are necessary. So we don't subject the majority of patients to these tests. We kind of use it as rarely and as clinically appropriate. So we've talked a lot about diagnosis, and I want to hone in now on the Bush-Francis Catatonia rating scale, which we use to confirm the diagnosis, but also to monitor severity and treatment response. Bush-Francis is a widely accepted scale, and what I love about it is that it includes really helpful training modules online, linked here in this QR code. You can also Google Bush-Francis, Catatonia, and University of Rochester, and you will come to an educational website where they have outlined each of the 23 items on the screen. They have videos for each one showing what it looks like in a patient and how to score it on your Bush-Francis. So extremely clinically useful. I've used it many times. They also have quizzes available. They have training courses on catatonia. It's a really excellent resource. All that to say that it's really helpful to use the Bush-Francis because there's a lot, it's very widely used and accepted. There are other scales, but none compared to how widely used the Bush-Francis is. The lorazepam challenge is something that we can do if we have a patient, we think they have catatonia. This is a great way to both start their treatment and to confirm the diagnosis. So what you'll do is you'll get a baseline Bush-Francis score, and then you'll give the patient 2 milligrams of Ativan. If you have an elderly patient or a child, you may give 1 milligram, but generally 2 milligrams is the dose, and you'll administer it, and you will see if it's catatonia, typically responding catatonia, you will see a robust response, rapid improvement in symptoms. It's almost miraculous how quickly people start to look better. They'll start talking normally, interacting. Then you'll recheck, after you see that improvement, you'll recheck the Bush-Francis. And if they have a 50% or more reduction in their score, that is diagnostic of catatonia. So in the literature, it's often recommended to do an IV dose of Ativan, but realistically in a psychiatric setting, we often don't have IV access in our patients. On the medical unit, if they have a known medical condition they're being treated for, that would be, appropriate to use IV Ativan to do this challenge. And in those cases, it works so quickly, you'll see the response within a minute, 1 to 3 minutes. And it's a little bit slower with oral, but it's still pretty quick. And you'll see the response sooner than the 2 hours time to effect cited on this slide. I am somewhere in the middle, a little bit, faster than oral, but slower than IV. Can be traumatic to the patient though, to get a shot of a medication. So you'll use your judgment on how to administer that Ativan. First line treatment, as I've mentioned, benzodiazepines. They are the mainstay of treatment, and somewhere between 66 to 100% of patients, depending on what source you're using, respond positively to a benzo. Lorazepam has the most evidence behind it. It's best described in the literature. However, diazepam also appears to be effective. We just don't have any head-to-head trials comparing one to the other. And when you're giving a benzo, specifically Ativan, for catatonia, you are going to be dosing it every 6 to 8 hours, so 3 to 4 times a day. And the doses needed in catatonia are much higher than most of us have ever seen for other things or are comfortable with for other indications. And you'll see a response generally very quickly, max response will be within the first few days. So if you're not seeing a response early on in the course, you're going to want to move on to the next attempted treatment. ECT is also gold standard electroconvulsive therapy and improves 80 to 100% of patients with catatonia. Although ECT is not available everywhere, and obviously it's a procedure, it involves anesthesia, so it's a little bit more intensive. However, if someone is not responding well enough to benzos, that's when you'd go to ECT. And then if someone has malignant catatonia, that is when you'll emergently, as soon as possible, start ECT, because that is the gold standard treatment for malignant catatonia and will help with their outcome. When ECT is given, it's typically given 3 times a week. It's often, often patients are needing maybe 12 treatments, so several weeks, and then also maintenance treatment once that initial course is done. And we may be having, later on in the series, hopefully we'll be having a talk on ECT. We're working on trying to get someone here to talk a little bit more and sort of destigmatize ECT, because it's a really useful treatment. Obviously, at the same time you're treating the catatonia itself, you are going to be treating whatever is the underlying condition. You're going to be monitoring them closely to make sure they're not worsening. You're going to be supporting them, giving IV fluids if needed and in the right setting. So this is all sort of in parallel. Most patients do respond to benzos, but if not, there are a number of other agents that are being studied and that can be helpful. So these include glutamate antagonists and NMDA receptor antagonists like amantadine and memantine. These include, there's also evidence for antiepileptics like Depakote or valproic acid and carbamazepine. And then zolpidem can be helpful, as well as benztropine. And so these treatments all have less evidence. They're less studied than benzos. They can be used either in conjunction with benzos if someone is having a partial response to the benzos, but not complete, or they can also be trialed as monotherapy if someone, for some reason, has no response to benzos or has a contraindication to benzos. So antipsychotics have been used in catatonia for decades, and they are still one of the very most controversial aspects of catatonia management. I was taught, and most of us were taught, that if someone has catatonia, you are to hold the antipsychotic until the episode has resolved, because antipsychotics can increase the risk of NMS, they can increase the risk of malignant catatonia. But it's important to note that in patients who are psychotic and who have an underlying psychotic disorder, antipsychotics are a hugely important part of their treatment. And so I sort of made a decision tree here to kind of walk through what best practice would be in considering this question. And the first part of it is the psychosis prominent? If it's not, if someone is on an antipsychotic for a reason other than psychosis or an off-label indication, then you would hold it to be extra cautious. If the patient is on it and psychosis is a prominent part of their clinical picture, you're then going to ask if there's any suspicion for NMS, if there's any increase in rigidity or signs, elevated temperature, for example. Then you're going to want to hold the antipsychotic because the risk is just too high of the antipsychotic exacerbating that. If there's no suspicion for NMS, then you're going to think next about what agent it is that they're on. High potency first generation antipsychotics are higher risk overall for precipitating malignant catatonia. And so these are going to be ideally stopped and switched to a lower risk second generation antipsychotic that has less risk of worsening their condition. If you are using if you're going to proceed and go ahead with the second generation antipsychotic, it's important to monitor them closely, make sure you're checking vitals. This is why they're in the hospital. you have close eyes on them, and you're just going to want to proceed carefully and intervene early if there's any evidence of a worse presentation. So sort of the bottom line here is there is a role for antipsychotics in patients with catatonia and an underlying psychotic disorder. But the antipsychotics should be chosen and used very carefully because they do increase the risk. So it's not risk-free. So it's a careful clinical decision that you're going to make depending on your individual patient. This paper is a pretty new, this year, systematic review of the use of antipsychotics in patients, in 175 trials of patients with catatonia. And what I wanted to draw your attention to is the part that I've kind of boxed in here under results. And that is that this study showed that antipsychotics were beneficial in 60% of trials. And they define beneficial as improving catatonic symptoms or complete recovery. They were neutral. Antipsychotic use was neutral in 29.1% of cases, so didn't have an impact on catatonic signs. And then there were 10.9% of cases for which antipsychotic use was harmful. And in those cases, it worsened their catatonia or led to malignant catatonia or NMS. So, this kind of gives you a sense of the risk. And I certainly wouldn't feel comfortable blanketly saying it's safe to use an antipsychotic in catatonia when there's a risk of poor outcomes in 11%. That's too high for comfort. And so, but in most cases, it is going to be okay. So that's why there's really careful decision-making that needs to go into this and why the patient should be in the hospital. So as I mentioned at the beginning, this talk grew out of a clinical question I had, which is, what is best practice for caring for a patient after they're discharged from the hospital with a recovered episode of catatonia, but they're still on high doses of benzodiazepines? Now, benzodiazepines are not long-term medications for the majority of people. Granted, there are always some exceptions of patients who have really severe really stubborn, resistant catatonia that whenever you try to wean them, they develop symptoms again. But this is the minority. The majority of patients will be able to be weaned off of the benzo. And so you're going to want to wean slowly and avoid abruptly stopping the medication because that can lead to recurrence of symptoms. You can kind of precipitate a recurrence of symptoms. And it could also lead to withdrawal, depending on if they'd been on it for a long time. So according to a recent systematic review, there are no studies on benzodiazepine tapering and discontinuation after resolved catatonia. So how do we proceed with tapering someone? Tapering is generally quite an individualized process. Some patients, will do well with a quicker taper, but others will, a lot of times, ideally, it takes months to taper someone off of a benzo, and you're going to do so generally about 25% a week. In the inpatient unit, they can taper a lot more quickly because they have close eyes on a patient. But if someone's on, 16 milligrams of Ativan a day and their catatonia is better, they're not going to hold them in the hospital to wean them off of the benzo because, we want to give patients their freedom back as soon as possible and keep them in the least restrictive setting. So generally, we're not holding people to kind of get them off their benzos, but it does result in people leaving the hospital on doses of benzos that might make a provider who doesn't see catatonia much or hasn't had much experience with catatonia extremely worried. So, and some, I've talked to folks over at the hospital who have said it's really hard to discharge people after catatonia to outpatient clinics because a lot of people don't have the experience dealing with these high doses. So part of the goal of this talk is to sort of improve comfort and talk through strategies in doing these tapers of high doses. So some of the things that you're going to think about when you're tapering someone, I kind of walk through a multi-step decision process when I'm designing a taper for a patient. And so the first step is, how much am I comfortable reducing each week or 2 weeks, whatever your interval is. And generally 15 to 25% is pretty safe. You might be limited by what your tablet strengths are. So for example, Ativan, you're not going to be able to reduce by like 0.375. You're going to reduce by 0.5 or 1. And your next decision after you decide how much you're going to taper is how quickly you're going to taper. So how often are we going to make changes? And also, when you're making your changes, which specific doses are we removing the 15, 25% from? This can change from week to week. This could be from each separate dose, or we'll walk through a specific example where I tend to preferentially try to eliminate, if someone's on 3 times a day Ativan, I try to preferentially often, unless the patient doesn't want this, but try to preferentially remove the middle dose, because 3 times a day medication is quite difficult to adhere to. You can also convert them to a longer acting agent, for example, Klonopin or clonazepam or diazepam or Valium for less frequent dosing. And in this next step, I apologize, it's fairly tedious for the non-prescribers, but I wanted to walk you through a real example of a taper that I did with a patient, because we really don't, it's sort of usually a self-taught thing, and it does take some practice and some comfort to get used to. So again, apologize if this feels tedious, but this is an example of a patient that came to me on 3 milligrams of Ativan 3 times a day. And so my first question, and for the first meeting with this patient, I tried to lay out a plan in advance, and it's always subject to change. We always have to be humble and modest about things not going according to plan. We always have to take in the patient's feedback. So I'm not suggesting we make a plan up front and be very rigid about adhering to it. I just think it can be helpful to give the patient a sense of how things might go, and to just kind of feel good about having a plan and knowing that you'll get the patient down to more reasonable and ultimately no benzodiazepines. So this patient, as I said, 3 milligrams 3 times a day. The first step is, so that's a total of 9 milligrams. The first step is, what's 15% of 9? Well, that's 1.35. 20% would be 1.8, 25%, 2.25. So I know going in that I'm going to want to decrease that first step by somewhere between 1.35 and 2.25. There are really only 2 options that are feasible unless you're using like a suspension that's been compounded. Really, most feasible is going to be a reduction by 1.5 or by 2. And so I laid out each of these options of reduction by 1.5. If you want to be, the more aggressive, slightly more aggressive, but still safe option would be to reduce 2. And so in this case, I was aiming to get rid of that midday dose early, because this patient didn't have, he had a visiting nurse twice a day. So that was a factor that kind of played in, and had minimal oversight sort of in the middle of the day. So here's our first line where we started. Week 1, I ended up doing a 2 milligram reduction, took it out of the midday dose. And so new total 7 milligrams. And then we won't go through this each step again, but we have 7 milligrams now. We calculate what the options are for reducing between 15 and 25% of that. And due to the tablet sizes, again, it was either 1 or 1.5. And so I took the middle dose away completely. That was 1 milligram of it. And then I had 0.5 left that I could reduce from either the morning or the evening dose. And generally, when I'm tapering a sedating medication, it's kind of an easy choice to get rid of the morning dose first. That said, benzos aren't sedating in these patients. That is kind of my approach when I'm tapering a twice daily antipsychotic. But for catatonia, I like to also preferentially start with the morning dose. Again, if the patient is comfortable with that and okay with that, because if they're not going to tolerate that reduction, if they're going to develop some symptoms, We want it to be when we're going to be witnessing it, or someone hopefully will be witnessing it, so it can be caught early and we can kind of go back up on the dose. If we're reducing it only from the nighttime dose, we may not really see it because hopefully the patient is sleeping. And so there's no right answer of what you do when you taper, but these are sort of some of the things that I think about. For those who are interested, I kind of walk through each next step. We're not going to go through them, but as you get kind of further into your taper, because of smaller doses and the availability of only certain tablet sizes, you have fewer options. And so there's less choice in your total amount that you're going to reduce. So it sort of almost lays itself out just using the same principles. And so this is the rest of the taper for the patient. It ultimately took 11 weeks. There are many correct ways to taper. This is not the only strategy. You could have done it a completely different way. Really the important thing is to be in good communication between appointments about how it's going. That is it for what I have for today. Here are some references if you're interested in learning more. I have my email address on the next slide. If there are questions, I'm happy to take them, but I'm also available by email if needed.